Warm. Thank you. Denise and I were chatting about, well, it's Heart Month in February, and we'd like to get the lecture series restarted. And I'm thinking, because of this pandemic and all of the restrictions that we've had, a lot of folks may not have had their regular follow-ups, their regular doctor appointments. And I think that is a little bit concerning. COVID Central is over at the hospital. So if you stay away from the hospital, you're in good shape. I would say don't skip your doctor's appointments. Go ahead and go to those, particularly now that you've had your immunizations. So that was one of the objectives for presenting this talk. The other objective is that as a geriatrician, I've discovered that many of the symptoms that we as older folks experience are different than, say, the 45-year-old who comes in to see me and says, oh, I've got this pain in my chest and it comes on every time with exertion and I get short of breath. And, those are symptoms, but they are so typical that it's a no-brainer. But when older folks come in, they don't typically have the same responses. Our responses are blunted, and it may just be a funny feeling instead of a crushing chest pain. But I was going to try to raise your awareness and get you to pay attention if there are symptoms and get some attention to your heart. I want to start with a caveat, and that is that if you're having a heart attack, do not, I repeat, do not drive yourself to the doctor's office or to the emergency room, because something could go wrong with your electrical system in the heart. You're driving along, and you've read about this, where people will have a medical problem and they will wreck their car. So you have someone take you, and better yet, go by ambulance, because if something were to happen with your rhythm in your heart, then they are trained to help fix that, and the survival is much better. So I'm going to give you a quiz. How do you get the ambulance?
Living here or anywhere?
Here.
Call the charge nurse or the front desk.
Mm-hmm. Yes. And I want to be sure that we know that if we dial 911, what happens? If we're on campus, it goes to 911, they get the call and they say, somebody must be having trouble over at Westminster Canterbury. And so they call over here and they ask the front desk, do you know there's a problem? There's a gentleman, Slusher, called us. And no, we don't know, but we'll go down there right now. So it just delays everything. Don't call 911 from the campus. Call the operator. That will put everything in motion. The clinic comes, the ambulance is summoned, and everything happens a little quicker. So 2 caveats: don't drive and don't pick up the phone and call 911. Okay. Well, as I mentioned, February is National Heart Month, and it's kind of like Valentine's Day. It's a holiday that's contrived by an organization, but in this case, the organization's American Heart Association, and I think they have our well-being in mind, as opposed to Valentine's Day, where they want our money for flowers and cards. But I think that we need to know that heart disease is probably what's going to get us. As these statistics point out, when you're in your 40s and 50s, about 40% prevalence of heart disease. But by the time you reach your 80s, it's an 80% prevalence of some sort of heart disease. And it accounts for 80% of all deaths over 65. So if we want to look at something that here's where the money is. You try to learn about heart, and you try to protect yourself and keep your heart working well. There are normal changes with aging, and this is what you find when you start looking in the books. But the books are comparing us to a 20-year-old. So when you see 50% fewer electrical cells, that's not as much of a problem as it sounds like. That's the normal process of aging. And 20-year-olds need their electrical cells more than we do. There's a decline in elasticity of the heart. They get stiff, the blood vessels get stiff, the chambers of the heart get stiff, and it has to work a little harder. Muscle fibers decrease, and fatty fibers and proteinaceous fibers increase. So the weight and the size of the heart is actually a little heavier in older people. The cardiac output, or the ejection fraction, goes down by about 3 teaspoons a year. So we're looking at a decrease in the amount of cardiac output. So that's why we don't have the same reserve that we used to have. We could work all day, lift that bar, tote that bale, but we can't do that anymore. There is a slight enlargement of the heart, and our response to adrenaline decreases. So adrenaline is that fight or flight hormone that drives your heart, and that is decreased as we get older. Okay, so there are normal changes, not to be confused with heart disease. Well, how can you tell if your heart is not well? And there are some general signs and symptoms, and one of those is that in January you noticed kind of an extreme tiredness set in, an unexplained drop in your energy, and it hasn't returned. That could just be the only sign or symptom you get of some heart disease. It could have other meanings. It could be some other condition. But when you see that happen and your reserve goes down and you have a drop in energy, after activity you just feel all in. You're just crashed. You can't return and recover as well as you did. If you have any unexplained chest symptoms, and I've had many patients who come in and say, it just feels funny in my chest. They don't have any specific pain or a symptom that tips you off, and so running an electrocardiogram, you find they're in atrial fibrillation. So if you have that sensation of an unexplained symptom, some kind of fluttering, pounding, maybe a cough that's suddenly come on, you need to get some attention for that. If you have awakening in the middle of the night and have to sit on the side of the bed to get your breath, and then you can lay back down and sleep the rest of the night, that's called paroxysmal nocturnal dyspnea, or PND, and that is a symptom and a sign of early heart problems. The new onset of anxiety or depression, you don't understand why. This can be related to changes in function. Unexpected swings in your weight, usually to the increased side. You've gained, we've all gained over the course of this pandemic. Hopefully some of you have been able to keep it off. I know I have not. But I know where that weight gain is. But if you have unexplained weight gain, you're not overeating into the cookies as much. It could be fluid retention. You may be finding yourself holding more water, and then you have to get up at night and go to the bathroom more frequently. If you have conditions such as high blood pressure or diabetes, and you have a sudden loss in control for no explainable reason, your diabetes is no longer in control. Your hemoglobin A1C has gone up, and you have symptoms. That can be the only tip-off that something might be wrong with the heart. You think it might be diabetes getting worse, but it just could be a response to injury in the heart. So as our little heart guy says, you get any of these symptoms, take me to the doctor and get me checked out. We're going to cover 4 different areas of heart disease. These are the main problems of heart and heart conditions. These problems are somewhat interdependent. For example, the first one we're going to talk about, coronary artery disease, can be a cause of the others, such as congestive heart failure or abnormal rhythm. So those are problems that are interdependent. But we all know what hardening of the arteries is. It's coronary artery disease. It's the deposition of plaque in the artery. A heart attack is a clot that forms because the opening is smaller. Maybe the clot forms or a tear in the lining, which is called the intima of the artery. And if there's a tear, because it's stiff and it's brittle and it cracks, then it can cause a dissection of that artery and a clot that forms in there. So those kinds of issues are long-standing. They're started when we're in our younger age because we do some of this. We have hypertension, smoking, diabetes, abnormal lipids, obesity, lack of exercise, chronic infection or inflammation. Interesting studies have been done about dentition and heart disease. And people who have chronically bad teeth with infection and gum disease have a higher incidence of inflammation in the heart and clot in the blood vessels. There are 2 things that are questionable. One I think is definite, but the other one I'm not sure what to do with, and that is sleep apnea. Sleep apnea has definitely been shown to increase congestive heart failure and to raise blood pressure. So I think it is a significant influence on our heart. However, high homocysteine levels, homocysteine is a chemical that floats around in our blood, and if you measure it and it's high, they think that is something that predisposes to heart disease, but that's still in the investigative stages. The diagnosis of coronary artery disease is usually made when someone presents with new onset symptoms, typical symptoms of crushing chest pain or angina or congestive heart failure, and then it's confirmed with an electrocardiogram, which may show a heart attack. I had a patient come in on a Monday who said, well, I had a cold last week, but I'm better now. But I do have this funny feeling in my chest. When I did an electrocardiogram, he had had an MI, myocardial infarction. So they can be silent. They can look like something else. Right there this is an angiogram, and the left anterior descending and the circumflex in here. The arrow is pointing to a clot right there in the artery. So let's look at some of these specific signs and symptoms. Steady, intense pain in the anterior chest or the anterior left chest. It's a crushing pain, it's a heavy pain. I've had it described as it feels like an elephant sitting on my chest, or it feels like a belt being put around my chest and tightened. So that's maybe a little bit atypical. Women tend to have less characteristic symptoms. Women do not have the typical angina. They may just have an ache in the jaw, an ache in their mid-back area, just next to the spine, or commonly they may have shoulder pain, accompanied by intense fear or dread if it's really severe, pale, sweating, short of breath, rapid heart rate, elevated blood pressure, and the symptoms decrease with rest or nitroglycerin. Women are more likely to have nausea and lightheadedness than men. You girls are different. But we, as older patients, are different. You know, there's a specialty called pediatrics, and we wouldn't think about going to a pediatrician to get our care. Well, there's a specialty called geriatrics. Unfortunately, it's not, there are not a lot of them in Lynchburg. But those are the people who study how diseases are manifest in the elderly and treat them differently than what the 45 or 50-year-old is being treated. So we all know that we watch television and the medical shows, and the guy that has the heart attack grabs his chest like this, bends over and falls to the floor. That is not as dramatic in us. We put up with a lot during our lives. We kind of, our mental mindset is, oh, it's just aging. We're going to have to put up with this. So it can be silent, it can be unnoticed, but anytime you get some sudden symptoms in the chest and they don't seem to go away, I think that would be suspicious, and you should call for help. Lightheadedness for no reason, cold or flu-like symptoms. As I mentioned, the gentleman that came to my office thought he had a cold and ended up having a heart attack. And sometimes these symptoms will not always be typical with exercise or overdoing it. They will come on at rest, and that's called unstable or Prinzmetal's angina. And when you get those kind of chest pains that occur at rest, those are a little bit more worrisome because that's an indication of a very unstable lesion in one of the coronary arteries. It's just kind of waiting to do bad things. So don't ignore that. Go in. Any questions about hardening of the arteries, atherosclerosis, coronary artery disease? I'm totally open to questions at any time. Just shoot your hand up and ask, okay? Well, now we're going to talk about congestive heart failure. And congestive heart failure is sometimes referred to as CHF or dropsy or weak heart. And congestive heart failure is often part of the final stages of heart disease. So everything else goes wrong first, and then the congestive failure is a lack of being able to compensate for injury. I'm going to make radiologists out of you here. We're going to look at this chest x-ray, and we'll just kind of look and see what can be seen. First of all, the chest, normally the heart is less than 50% of the span between the ribs. And you can see that it's greater here. I mean, you don't even have to measure it. That's more than 50%. And that's called an increased cardiothoracic ratio. So if the normal ratio, and I'm just going to pull numbers out of the air, it's 5 centimeters, and this is 12 centimeters, that would be 5 to 12. But an increased ratio would be when your heart size gets bigger, 8 to 12. Your chest size is probably not going to change. Curly B lines. These are signs of fluid in between the air cells of the lung, and they're just little straight, I don't know how well they are showing up for you, but they're little straight lines that come right out from the edge of the ribs, and they're only maybe a fourth of the distance here. But those are called curly B lines. Doesn't make any sense, does it, why it's called curly B lines, because they don't look curly. They're definitely straight, but then that's somebody who got their name on it. There are no Charlie D lines that I'm aware of. This is cephalization. Cephalization means moving toward the head, and vessels, cephalization of the vessels, and you can see it pretty clearly. This is a very good demonstration of how the blood vessels tend to increase in size and appear to be more prominent. And then here's a pleural effusion. This is water between the lobes of the lung. And here's the right upper lobe and the left lower lobe, and here's fluid in the fissure. And you can also see a lot of distension here in the mediastinum, which is this part of the heart that's called the mediastinum. And you see this is all congested fluid in here. So that's what we look for when we're trying to make a diagnosis of congestive heart failure. This is going to seem to be a little bit repetitious because all of those risk factors that I showed you before, plus these, are risk factors for congestive heart failure, but a prior myocardial infarction, diabetes mellitus, uncontrolled hypertension, valvular heart disease, a cardiomyopathy. A cardiomyopathy is where your muscle in your heart is affected by some abnormal protein or chemical, and it dies. Some of the muscle fibers die. Severe lung, kidney, or liver disease. There's a cardiorenal syndrome where if you have kidney failure, then you end up with heart trouble. Congestive heart failure is the leading cause of hospitalization in the elderly. So at 80% incidence or prevalence, this is going to show up in our lives sooner or later, probably. And our little heart friend down here is breathing near impossible. But the reason I stuck that in there is because BNP is natriuretic peptide, and it is a chemical in your bloodstream that's associated with heart failure. So if you hear your doctor say, well, I'm going to take a BNP test, that's what they're doing. They're trying to assess for congestive heart failure. Signs and symptoms. SOBOE stands for shortness of breath on exertion, and PND is paroxysmal nocturnal dyspnea. And this gentleman over here is giving you an example of that. You can see that he's got cyanosis or bluish color in his feet. Looks like he's got a lot of swelling. He's having some chest discomfort, and he's sitting up on the side of the bed in the middle of the night to get his breath, which after 20, 30 minutes, he gets his breath back and sleeps the rest of the night. So that is an early warning sign for sure. Swelling in the lower limbs, rapid or irregular heartbeat, persistent cough and wheezing, and sometimes there are conditions that are confused, like COPD and asthma. And when you have those conditions and then you start to cough and you start to wheeze, you kind of think, well, it's one of those conditions, but it might not be. It might be that fluid that we saw that gets in there in between the little lung cells and compresses and makes it harder to breathe. And the body's natural reaction is to do what's called PEEP, positive inspiratory pressure. And so when you cough, you put increased pressure down on your lung, and that pops those little air cells open. So the persistent cough could be a sign of lung disease, but it could also be a problem with heart disease. And for the guys in the room, it's kind of hard to know whether it's your heart or your age that's causing that, but it's definitely noticeable increased urine volumes. And oftentimes this will be apparent before bedtime, and in the morning it'll be gone. That's a good healthy sign. If it's still there in the morning, that's not a good healthy sign. That's heart disease. Now that you're mini doctors and I've given you this crash course in heart disease, I don't want you to try to diagnose yourself, okay? I want you to just take all of this as a recommendation that you might need help and to get a chance to go visit your doctor. But fatigue, weakness, these are probably, ageism is that you blame all of that on your age. But if all of a sudden your condition changes and you're not another year older, I think you better pay attention to that as a warning sign or symptom. Changes in mental status. Oxygen level can decrease with congestive heart failure, and mental status changes can come on. New onset atrial fibrillation, pretty good indicator that we're dealing with atherosclerosis and congestive heart failure. And we'll talk about atrial fib in a little bit. I hope I'm not using terms that are so foreign that you don't know what they are, but if I am, I wish you would say, don't talk doctor talk, talk people talk, and I'll try to explain it. Chronic obstructive pulmonary disease. If you have it, it gets worse in about 40% of heart failure patients. Now, if you're a little overweight, take heart. It's not a bad thing. And in fact, there is a U-shaped curve with weight, so that in your early years, the lower your weight, the healthier you are, and then your weight starts to increase a little bit as we get older because fat cells are deposited, we lose muscle mass, which is heavier than fat, and there are dietary changes in our life. But what we have seen as geriatricians is that if you treat and try to intervene in the weight gain down on this U-shaped curve, that's actually detrimental. The people will have a better quality of life and live longer if you just let them be. So that's the obesity paradox. You get a survival benefit from being a little overweight because you've got more reserves to call on. And the people who are very skinny and don't have that extra weight, they tend to have a shortening of their lifespan by about 6 months when you compare people equally. When you say, okay, this man and this man, they weigh this and they have the same conditions. So that over time, the obesity does help. Now, don't tell anybody I told you that. Okay. And as we get older, we're on more drugs. And the more drugs we're on, the more likely there's an adverse drug event. The research shows, pardon me, that you only have to have 5 drugs before you've got a drug-drug interaction. And if you've got 15 drugs, well, you know, you've got at least one, if not more, drug-drug interactions. So that's can be kind of detrimental also. Can't get your shoes on anymore. Edema fluid. This is pitting. You just put your thumb over the flat part of your shin, press and hold it for a few seconds and let it go, and you see a fingerprint. That's pitting edema. And if your weight changes more than 3 pounds in 24 hours, that's not fat. I think you could eat a whole box of Stover's candies and not gain 3 pounds overnight. So that's water, and that's a bad sign. Oop. All righty. This is starting to be repetitious, but modify your risk factors. Start to exercise. If you think that you have heart disease, don't do this on your own, and please don't show up in Denise's wellness center with chest pain because she doesn't want to deal with that. She's sitting back there going, no. You want to get permission for an exercise program, have a good physical exam, if need be an EKG or a chest x-ray, and get clearance. Try to control diabetes, because out of control diabetes is as strong a risk factor as smoking for heart disease. So we want that diabetes in good control. What is good control? Anything less than a hemoglobin A1C of 7 in our age group is good control. That's not true if you're 45. You want it to be less than 6. But God is graceful and gave us a little wiggle room as we get older. Try to limit yourself to 2 grams of salt per day. That can be hard if you're eating in the cafe. Sometimes there's a lot of salt in the meals that they cook. So 2 grams. If you are on a salt-retaining drug, and there are many of them, you want to try to get off of it if possible, if you have congestive heart failure. NSAIDs, non-steroidal anti-inflammatory drugs such as ibuprofen, Aleve, those are salt-retaining drugs. And over time, they will increase body fluids and cause more of a problem with heart failure. There's a whole list of drugs that can cause heart failure in and of themselves. So it's a side effect that we put a patient on a drug and we always follow their heart to make sure that nothing is changing. This little, you may want to remember Epocrates.com. Anybody can subscribe to that. It is an online pharmaceutical information database. And you can take all of your medications and put them in a list and then run a little thing that's called interaction check, and it will tell you what the interactions are. Or you can go and look up the material on a specific drug that you might be taking, so that if you're on amiodarone for control of heart rhythm, you can look it up and see what the side effects and interactions are. CPAP, are you familiar with that? It's continuous positive alveolar pressure, and that's for sleep apnea, and that does decrease fluid retention in heart disease. And keep those regular doctor visits. And this is me over here. I did try it once. Valvular heart disease. There are 4 valves in the heart. In this particular diagram, you can only see 3 of them. But here's the tricuspid valve, which is between the right atrium and the right ventricle. Here's the aortic valve, which comes off the left ventricle and is in a big kind of looping type blood vessel. And here is the mitral valve right here. This should not be there. That's a sign of aortic regurgitation, and that's valvular heart disease. So regurgitation, insufficiency, valvular stenosis, those are the terms that are associated with this particular condition. You're going to need treatment for this. There's no way around it. If you've got a valve, eventually something's going to have to be done to fix it, or it will give you a poor quality of life and limit your life. The causes can be many. You could have had a previous MI that damaged the valve. You could have had, there are little tethering chordotendonae, they're called, and they hold the valve in place and allow the valve to move. They're like little guy wires. And heart attacks will knock those things off. And when they are killed and they're no longer there, then the valve doesn't have the control that it needs. So those kinds of conditions can cause problems for you, and then it can be congenital, like a bicuspid aortic valve or a mitral valve prolapse. Those are things that we inherit in our genetics and carry with us through life, and they can get out of control later in life. Repetitious, but you can't think about this too much. Increased shortness of breath, palpitations, skip beats, swelling of the lower limbs and abdomen, chest discomfort, increasing fatigue and dizziness. I'm just reading those to you to try to get them into your brain. Heart valve disease. Here's a normal valve right here. This is a a cusp, and this is a cusp, and this is a cusp, so there are three of them, so this is a tricuspid valve. And normally it will open up and let things go through, and then it will close up and look like this again. So it keeps the blood flow moving without pushing back against the heart. But as a valve gets sclerosed and hardened, it doesn't close all the way, so that's when you get the regurgitation. Even when it's supposed to be closed, it's not, and you're getting some blood flow back in the wrong direction. And then valvular stenosis, it stays open. It never can return, it never gets back to this stage. So again, a lot of regurgitation. The replacements are either biologic valves, bovine or porcine valves, and that procedure's been around for a long time, or mechanical valves, and this is a mechanical valve here, and they're sewn into place. This is the only picture I could find pertinent to a mask in the pandemic, so there you go. And finally, we're going to finish up with abnormal rhythms. You know that old song, I got rhythm, da, 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 da. Well, you don't want rhythm in your heart. You want it to just beat and not play different tunes. The abnormalities can be tachycardia, which means too rapid, bradycardia, which means too slow, flutter, which means that it flutters, fibrillation, doesn't really contract, it just sits there like a bowl of jello and shakes like this. Dysrhythmia, I like this term better than arrhythmia. If you have arrhythmia, you're dead, you don't have any rhythm. So dysrhythm, but you're going to hear the term arrhythmia, and I probably used it in here somewhere too. But yeah, I did, there it is. Oh, except that's where it actually makes sense. Because when you have ventricular fibrillation, you have no rhythm. You have arrhythmia and heart block. Okay, now you already know how to read an X-ray, so now we're going to learn how to read an EKG. Again, don't try this at home. This is a normal EKG. And it will progress along. Electrical activity in the heart is measured across two electrodes. They actually measure it in 12 different directions. So that's why we have what's called a 12-lead ECG. This is the depolarization of the atria, this part right here. And the atria are controlled by this little pacemaker, which is called the sinoatrial node. And then this little pacemaker down here, which is called the atrioventricular node, it intercepts the electrical signal and passes it on down to the bottom of the heart. Wasn't God amazing? He designed all this. It's just amazing. But here's electrical activity, depolarization of the atria, and you get this wave right here. And then when it's passed on, you get this wave, which is the QRS wave. And then when everything goes to rest and fill up again, and this is the recovery of your heart, that's the T wave. And the heart's really not pumping at that point. It's relaxing and allowing blood to come back in. Now here's a normal EKG, normal heartbeat. This one is a fast or tachycardia. You can see that these little spikes occur more often. This is a bradycardia or a slow heartbeat. And normal is about 60 to 100. And this is irregularity. You can see here's one, then there's a gap, then here's another one, and then it looks kind of regular. And I think right here we're starting to see another gap. So those are the kinds of changes that occur on the electrocardiogram, and it's what your doctor will look for to diagnose an abnormal rhythm. I won't read it to you this time, but I do want to point this out, that if your heart rate is consistently below 50, that's too slow. If it's in the 40s, if it's lower than the 40s, you need to be in the ambulance. Fainting or sudden falling out, that's particularly true when there's a ventricular dysrhythmia or arrhythmia where the ventricular system does not contract. Look at all this long list of causes. You consider yourself pretty lucky if you can miss all of those in your life. So you need to be able to take your pulse. So everybody try it and see if you can find it. And I'll show you, here's your thumb, here's the base of your thumb. And right in that base, there's a little groove, and the artery sits down in that groove. And you have to press rather firmly to feel it. Anybody not able to find their pulse? You can come up, and we'll work on it later. When you are checking your pulse in your neck, never do it this way. Don't feel both sides at the same time. And press lightly. There are some baroreceptors, pressure receptors in the neck, right about in this area here. And that baroreceptor will slow your heart or even stop it temporarily if you press too hard. That's the mechanism of the old sleeper hold, you know, when the wrestlers lock their arm around their competitor's neck and hold it and squeeze. They're squeezing on that baroreceptor and they pass out. So you don't want that. Well, here's the new Apple Watch that has the EKG. So that's why I taught you how to read EKGs. If you got money that you want to invest in Apple, you can get yourself a new Apple Watch with an EKG. Now, if you've got a history of arrhythmias, dysrhythmias, atrial fib, going in and out, this might be a good investment because you can kind of monitor it yourself, and if you get a change, you can call your doctor about it. Okay, we're going to look at these EKGs just so you know. Here's the sinus rhythm, normal P wave, QRS, T wave, a refractory period, and then it all starts over again. This is called a nodal rhythm. You remember I showed you those little nodes, the SA node and the AV node? If they get attacked by a heart attack, they aren't going to work. And here you can see that there's no P wave here. This is the P wave because the SA node has been knocked out. So it's a nodal rhythm, and this is a much more unstable rhythm than the normal sinus rhythm. But again, we're looking for a P wave, and it's not there. This is heart block. And heart block means there is a P wave, QRS, T wave, P wave, no QRS. There should be one right there. Here's another one, no QRS. You cannot feel the atrium in your pulse. You cannot feel an atrial pulse. It's too weak. So you're going to perceive this as a big gap. You're going to have one normal beat and a big gap and then another normal beat. And this is where that heart rate of 50 comes in, because this particular condition of heart block usually has a rate of 40. So you want to be careful of that. Now, Harold, I know you've been in the wood shop. What does that look like, and what tool does that look like in the wood shop? Right here. Okay, I'm sorry. Well, it looks like a saw, doesn't it? Yeah, it looks like a saw blade. Well, doctors are so original that we call this a sawtooth pattern. because it looks just exactly like that with nice sharp points on it. And these are atrial beats that are coming too rapidly, and then a QRS. And notice that there's a different space between the QRSs. And you perceive that as a very irregular pulse. This is atrial fibrillation. Atrial flutter is usually faster than atrial fib, but atrial fib can be as much as 150 beats a minute. And your heart can't sustain that for too long. So if you have this condition, you need to get it treated. Chronic atrial fibrillation in the range of 100 to 60 is not as much of a problem, but it might be associated with blood clots. So usually there's a blood thinner or at least aspirin. And this is ventricular fibrillation, and I like to think of that as a bowl of Jell-O that you just set on the table and it just sits there and wiggles like that. That's atrial fib. There's nothing that is being conducted through the heart. No blood is passing through because the ventricle just sits there like this and does nothing. Questions? You all ready to read EKGs now? Okay. Well, this one is more critical because if you have something like this condition, you need to get it treated sooner rather than later because treatment will be more successful. For example, in atrial fibrillation, if you have new onset atrial fibrillation and you're thinking about getting it treated, either by catheter ablation or being put on medical treatment, it's always more successful if you get on top of that early. The longer you wait, the less successful it is. There are drugs that can be used that will control the rate and the rhythm. Electrical cardioversion, which is where they put the catheter into your heart and convert if they know that there's a particular electrical focus, or they will put you to sleep and use a very low level just like a defibrillation. You see them in the medical shows where they put the paddles on and the patient goes like that. Well, they can do that under anesthesia and convert that rate back to a normal heart rate.
Then if you have three leads going into the heart, then you have electrical lead in the middle sometimes, electro.
Yes. This is a pacemaker over here. And the pacemaker is what we refer to as an implantable device. And it can be one of two kinds. It can be a pacemaker or a pacemaker defibrillator. And the defibrillator is used when the heart goes into ventricular tachycardia or ventricular arrhythmia, fibrillation. The pacemaker is used to drive the rate. So if your rate is 50 and you want to bring it up to 70, that's what the pacemaker part of it is. So there's a battery here that's implanted right here on the left chest under the skin. If anybody's had trauma or problems in that area, it may not be on that side. They may have moved it to the other side, but 9 times out of 10 it'll be on the left side. And then there are wires that are leading out of the battery, and those wires feed into the venous system down into the right atrium, and here it is touching the ventricle, and that's what triggers the pulse in your heart. Does that explain it?
I thought there were three circuits.
He thought there were 3 leads instead of 2. He has a pacemaker.
As you can see, there are just 2 wires here, but there might be 3 if it's a defibrillator pacemaker. There's going to be a different configuration. Okay, well, I've walked you through it. I think you should be more familiar with the kinds of heart disease that we're all likely to run into at some time in our life. And hopefully, we're going to be in the 20%, not the 80%. But you should know that there are definite warning signs and symptoms, that you should not drive yourself to the hospital to get this looked at, but get yourself to be driven or have an ambulance deliver you. And that's all. I'll be glad to answer any questions that you have.